Right. Welcome back to those who are joining us here. Good afternoon and welcome to this session on day 2 of the SCAGO Summit. My name is Dr. Madeline Verhovsek. I'm an adult hematologist and the co-director of our combined pediatric adult hemoglobinopathy clinic at Hamilton Health Sciences, McMaster Children's Hospital. I'll be moderating today's session on transfusion medicine in sickle cell disease. And if you or members of your network would like to refer back to the information shared in this session, a recording of the session will be posted on our website for viewing at your convenience. So that's on the SCAGO website. In this session, we'll be hearing from Juliet Uchegbue and Dr. Aditi Khandelwal, who I will introduce shortly. We'll start with housekeeping rules, which will then be followed by the presentations for our guest speakers and then a Q&A session. Oh, I've got something here that we're having a hard time with the audio. I'll just ask, we'll pause there for a sec and see if our SCAGO support team, Sam, can help out. Oh, sorry, all good now. Excellent, thanks, Karen. So we'll just quickly go through some housekeeping rules. Number 1, your microphones have been disabled for the duration of the webinar. If you'd like to ask a question, please do so by putting your questions in the chat or the Q&A function or by raising your hand. And we'll try our best to answer all of the questions at a latter portion of the session where the guests will be able to answer questions individually. And we're really going to try to emphasize interaction, I think, through a lot of the time today. There is translation captioning provided. You can do this by clicking the show caption at the bottom of the Zoom screen. Check the enable translation checkbox and choose the language you want the caption to be translated in. In terms of the chat, we'll kindly ask you to use respectful language and please do not post other material unrelated to today's discussion topic. We'll keep the discussions and comments on topic as much as possible, and the SCAGO does reserve the right to pause the session or to seek removal of participants who do not abide by these rules. Thank you for your understanding and agreement to positive participation. And without any further ado, I'm going to introduce our 2 presenters today. Juliet Uchegbue is a sickle cell warrior and a dedicated registered nurse. Juliet has 14 years experience in community health, palliative care case management, hospital case management, and alternate level of care, long-term care assessments and placements. She's also a PSW instructor at a Toronto college. Juliet has long-standing passion and compassion for caring for people from diverse population and continues to show support and train new nurses transitioning into the nursing workforce. Juliet earned her bachelor's degree in nursing from Toronto Metropolitan University and her master's degree in public health from University of Waterloo. Outside of work, Juliet enjoys spending time visiting family in USA, reading clinical research articles, visiting her friends, and volunteering at her local church. To her, faith, family, friends are her core support system. She describes her whole life to be centered on her faith in God and draws from that strength in her daily journey. And I'll also introduce Dr. Aditi Khandelwal. She'll be speaking second. She currently works at Canadian Blood Services as a medical officer and a hematologist and transfusion specialist at St. Michael's Hospital and Sunnybrook Health Sciences in Toronto. Dr. Khandelwal completed her medical degree at McGill University and her postgraduate training in internal medicine, hematology, transfusion medicine, and a master's in system leadership and innovation at the University of Toronto. More importantly, and this is in Dr. Khandelwal's words, not mine, she is a proud naturalized Canadian, a daughter to 2 aging parents who bravely started their life anew in a foreign land, a sister to an assault survivor, an aunt to 2 happy boys with the brightest sparkle in their eye, and a dog parent. She is a stem cell registrant, previously a blood donor, no longer eligible. Join the club, I'm in that same group. A blood prescriber, a passionate advocate for improving blood use and availability, and a medical educator. She's willing to talk to anyone who wants to donate and will hold your hand through the process. So we've got really some amazing expertise here on our panel. And I'm going to hand things over to Juliet, who will tell us more about her experiences as a blood transfusion recipient.
Thank you so much for having me. I really appreciate the opportunity to be sharing my experiences as a patient, because I believe this event and this session is also centered on the patient and delivering quality care always to our patient. And it's always good to hear from the patient point of view. So I started struggling with sickle cell disease from a very, very, very young age, maybe probably 6. And I've lived with it all through my life. And I became a nurse also because of my health. I want to know how to look after myself and advocate for myself, and then also look after other people. So it's like 2 goals in one shot. My challenges started probably in my early 20s. Back in, I think, 2015, I had a very terrible pain crisis that even resulted to me being airlifted from Mississauga Hospital, Community Hospital to Toronto General Hospital in downtown. I was rushed to ICU. There was, I think, after I was a bit conscious, I was told I had something called exchange. There was a tube inserted in my neck called the jugular vein, so it's on the neck. That's where they had the exchange, and the transfusions happened. Unfortunately, I developed some complications right after the transfusion. Right away, I started my hemoglobin, instead of going up after getting blood, which you normally see, my hemoglobin started decreasing because my blood quickly was hemolyzing. And by the time the doctors realized, my hemoglobin dropped to like, I think 30. And that was scary for everyone. I turned pale. I always was unconscious, sort of. I was drifting in and out of consciousness. I remember them paging every doctor they could find, all the hematologists, even across the network, to come to Toronto General for help. They were all running around. I remember one of the doctors that worked with transfusions and she was actually about to catch a flight in a few hours from that call. But she was able to intervene quickly, and they came up with some plan to give a medication. I can't remember the names now. But soon after, I was rushed back again to the theater, brought back. It was just back and forth. I thought I was actually dying. I saw my life. People say when things happen, your life flash right in front of you. I saw my life just flashing and drifting away slowly. I remember my mom, my sister holding hands, praying beside me. I know they probably thought I was going, like I was probably gone. I don't know where I was. My blood depleted. I was having so much pain. Medication was not cutting it. Morphine, everything. I was even reacting to morphine. That's why morphine is part of my allergies today, because I was even reacting to the morphine. Only the hydromorphine helped. So for the transfusion, they did an exchange, and after all the tests were done, they realized that I had developed so much antibodies. After that hospital admission, when I was discharged, they gave me a card to show anywhere I go in the world, anywhere I travel to make sure I always show that card so that they know. And my hematologist made it clear, it is in my chart, that I cannot get transfusion, no matter what my hemoglobin is, unless it is a life or death situation. Unless it's an emergency, I will not get transfusion. And since then, I haven't had any transfusion. So how did I manage? I started doing more juicing with spinach, because I know that is how I could bump up my hemoglobin. I started eating more red meat, iron. I needed all of that. I was juicing every day. I will have a glass of raw spinach with all the fruits that I like in it mixed together. That became my water. I was taking it like 3-4 times a day. And over the years, I built my hemoglobin with that. And we went back to RNFs or EPO to build the red blood cell. Then fast forward to 2023, this year, February, I had another complication from sickle cell disease, which is called AVN, avascular necrosis in the left hip. I was completely bed bound. I couldn't move. And when the x-rays came back, it was a fracture, and they had to take me in for surgery. Now, everybody have to come back on the panel. What do we do? This lady cannot go for surgery without blood transfusion, and she is not a good candidate for blood transfusion because of the antibodies. This could be very fatal. Even saving the hip might not be even worth it anymore if we lose her, right? So it took, by the time I had the surgery, it took months and months of deliberation. Actually, the deliberation started in December when I was actually admitted, but I didn't have the surgery until February because they were, my team was worried as well, and they had to come up with a plan. They had to do a research to know how to help me. And my doctor told me the thing they were going to do, I'm the only person they've ever tried it on live since school. They started it in school, but this is something they have to do live with me. If it works, then I might even use it in future for, let's say, the bone marrow transplant that we were talking about. So I had a manual, they call it manual exchange. And there was another thing, and there was a medication I had to have 2 days or a day before the exchange. And then I'm sure one of the doctor can share the name or the process. And then there's another, you take the medication again, and then you do it. You do another dose of it few days or a day before surgery. And within 24 hours, you must go into the theater. Must. There's no cancellation. It has to be all planned. Everybody was in sync. ICU was booked on the surgery day so that in case something happens, Juliet is going to be admitted there. She's not going to go on a post-op. There's no post-op. They had bloods ready. Everything was laid out for me for that surgery. So that, and luckily everything they worked out, and I went for the left hip replacement. And I came out with no complications on that side, and the blood was fine. Managed to get through surgery and came out with about 60% on my hemoglobin. And I didn't even need a post-op. I didn't need the ICU, so I went straight back to the unit. So that is my brief story and experience with a transfusion. And I must say that it's very scary. And this is the life of every sickle cell patient, the fear of when your hemoglobin would drop suddenly and you would become so anemic, tired, fatigued, no appetite, and even you don't want to do anything, you get depressed. And what do? It is scary. And I just can't, now I'm becoming emotional. It is a very scary time. So transfusion is not, it's not an easy topic for any sickle cell warrior. They will tell you it is a very scary thing to think of or to go through. And you get scared too, even if you're doing fine now, when am I going to get those antibodies? And how many antibodies can I get away with? For me, it was, I had enough, like enough was just enough for me that I couldn't even have transfusion. So can you imagine from 2016 or so was the last transfusion up until 2023.
Mm-hmm. Thank you so much for sharing that story, Juliet. I know going through and telling it probably again brings back very challenging memories from the time that it all happened, and also just the recovery period, right? That you would have had to go through. So I'm very glad that you and your team were able to safely and successfully get through this surgery earlier this year. And you've really given us a great start to the session in understanding. A lot of people know about blood transfusions and that sickle cell is it's so common to get a blood transfusion for sickle cell warriors. And then there are sometimes the rare but challenging complications that can come up with that. So I'm going to hand things over to Dr. Aditi Khandelwal, who has some presentation for us today, as well as I think we've got a lot of flexibility in what we decide to focus on during the discussion at the end. So over to you, Dr. Khandelwal.
Thank you so much. Thank you to you, Juliet, first and foremost, for sharing that story. I got really emotional hearing it because that is perhaps one of the hardest things to go through as an individual, as a person, and you truly are a warrior. Then a big thank you to Skago for being interested in hearing from the blood systems perspective. The theme this year is advocacy in sickle cell disease. And as you highlighted very nicely, Julia, transfusions are complex. What happens in the hospital is part of the story. And there's a whole bunch of background machinery in process to make this happen. And there are many, many time points in which we can potentially make things better for people like yourself and everybody else who is living with sickle cell disease when it comes to improving the blood system and making sure we can get the most out of it. Because at the end of the day, the blood system is here for all of us, theoretically, but it needs to be here for all of us. My name is Aditi. I use the pronouns she and her. And I'm coming to you today from the traditional territories of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. So I'm very lucky to call Toronto home. Let's see here if I can progress these slides. Okay, great. So I will provide you some context about some of the transfusion best practices that were introduced in the American Society of Hematology 2020 guidelines. But the reason I'm providing you this is not because we're going to debate the merits of the actual science. We're actually going to talk about how the various parts of the blood system and the blood operator, like Canadian Blood Services, needs to interact with the hospital system and our patients to make sure these actually happen. Like, how do we make best practices happen, right? And it's mostly to start a dialogue. So I'm hoping this will be brief and we'll get an opportunity to talk together. Here are some acronyms. I know there are people here from many walks of life, so I just want to kind of root us in some ways I think about some of these words that we throw around in medicine. SCD is an acronym I've used in the slide deck for sickle cell disease. Blood, you're talking to a hematologist, right? So blood means a lot of things to me. So the way the blood, I'm going to talk about blood in this situation, is a tissue that flows throughout our body. It's made up of many things. Red blood cells is one of those things. There's also a lot of water and proteins and nutrients, a lot of critical functions. It's a vital part of our immune system. It's vital to get oxygen to our organs. It's an important tissue all over our body. Transfusion. So as a transfusion specialist, I think of transfusion as a therapy. It is a biological, a living medication. It is manufactured from other people's blood. So without a donor, there would never be an opportunity to have this precious source of medication, this biologic therapy. It goes through many steps to be processed into the therapy, like a red cell concentrate that is then provided to a person who needs it. So that's transfusion. Red blood cell typing is another topic that Juliet's already alluded to because she had mentioned antibodies as well. Red blood cell typing is when we try to understand what markers or what antigens are present on the surface of the red blood cell. The reason this is important is this is what our body uses to know, hey, this blood cell is my blood cell. It has the unique markers of me. And an antibody on it for a red blood cell is basically your body's response to making these proteins that are supposed to protect our body. Because what they do is they recognize anything that doesn't look like them. These are antibodies, are proteins attacking the markers that are on top of the red blood cell. And that's the context in which we will talk about antibodies in this talk. Juliet has generously shared her story, and I also wanted to bring you Aaliyah's story. Aaliyah is a 5-year-old, was a 5-year-old when she actually experienced this. Aaliyah was born in Tanzania, and she lives in British Columbia. And it wasn't until she was 5 and she was here in Canada that she had one of the worst sickle cell crises of her life, partially because of the weather. It was really cold and she'd never experienced that before. She had a life-threatening complication and needed transfusions. It also turned out that she had one of those really rare blood types. And for that blood type, there may be about 70 people in the country who are donors who have that blood type. There's a lot more people in the country who have the blood type, but in our active donor base at the time, there were 70 donors who were there. And many of these people respond to the call to come in and donate blood for Aaliyah on an ongoing basis. And even today, Aaliyah receives regular transfusions to support her, to prevent further complications. And this roster of about 70 people are her army. They come in and month out and donate blood so she can get her 4 to 5 units every month. So I found that really beautiful, and her family shared her story as well. And I've linked for that for you there. So this is why we're here, right? At the end of the day, we're here because people need to have safe and effective transfusion therapy. And in sickle cell, when people are living with sickle cell disease, the guidelines say that the first time anybody is recognized to have sickle cell disease, at their very first visit, there are certain things we must do. There are ways of preparing for a possibility of transfusion. And one of the first things we're supposed to do is to understand those markers that are on the red cells. We're supposed to do this either by something called phenotyping or by something called genotyping. Once that is done, we also need to understand if there are any detectable antibodies in their sample. The interesting thing and the really complicated thing that sometimes happens in sickle cell disease is that when people form antibodies, these antibodies can hide if they're not detected at the right time. So we start off with having a baseline of what we know about the antibodies, but we always have to keep checking. Okay, so the antibody screen must be repeated regularly. All of this must also happen with the understanding that people should not be exposed to this biologic medication because it has side effects, and they are extremely important and difficult to actually predict and manage in people living with sickle cell disease. So many reasons why folks who have sickle cell disease they do have higher risk of developing the kinds of complications that Juliet had experienced as well. And we have to make these test results available from everywhere. Now that is in the guideline, but that is a huge challenge, even inside of one province in Canada of Ontario. So imagine people traveling elsewhere. Our known gaps in just the basics include the fact that not every hospital has the expertise or the materials or the ability to do what we call the typing. Serological or phenotyping can be done at some hospitals, but the genotyping is very expensive and is not done regularly at every hospital. It is for people outside of Quebec. It is done at Canadian Blood Services. Even the genotyping assays are limited by what we have available currently. And that's another interesting piece because these assays can miss markers as well. They're not perfect. And as a result, we need to push for better genotyping in this country. These are international standard assays that are licensed for this purpose, but they're still not as good as they need to be. Very importantly, when somebody does have testing done, these test results may not be available depending on where they're going. It may only be available in the blood bank where the testing was done. And Juliet spoke to this very nicely because Juliet mentioned a card. Juliet carries a card with this information. And one of the reasons for that is that we don't have universal and easy access to critical results when it comes to blood typing and antibody screening. This is all before a transfusion is even done. When a transfusion is required, testing needs to be repeated to make sure there's nothing new that is being missed in the antibodies, for instance, and matching needs to be done. Anybody else who does not have sickle cell will have a very different type of matching. They will be matched for something called the ABO markers. We've all heard A pause, B pause, people are talking about the ABO markers, and they're talking about one type of RH, which is called RHD marker. However, the guidelines suggest, and this is what we must do, is that people who are living with sickle cell disease, if they ever need a transfusion, at a minimum, they need to be matched for ABO markers, RHDCE, CAL, and anything they may have antibodies against, and more markers if we have the ability to do so. This one critical step can reduce the chances of forming life-threatening antibodies and then the blood breakdown that happens that Juliet had described with hemolysis, at least twofold. One of the challenges here is a limited inventory of blood type that is available. If somebody happens to have a much less common blood type and needs transfusion immediately, there may be a lag, but we need to improve that time frame. If somebody has rare blood, we may only have frozen blood available, which needs to be thawed and delivered to wherever the person needs it. And there may be a time gap associated with that. The job's not done when a transfusion is given. We need to watch. We need to watch very carefully for any complications like the red cell breakdown that Juliet had described. Delayed and hyperhemolysis are these dreaded complications that we worry about with transfusion. They happen somewhere around 5% of the time a transfusion is given to somebody who has sickle cell disease, and is far less common in any other situation. So we must watch out for this. And then we need to also watch out for any antibodies that form. About 25% of people who have sickle cell disease will also develop antibodies because of exposure to blood. And that is a large chunk of people, and we can't miss them. We only have a window of opportunity, a narrow window, to find these antibodies because they can then hide. And we don't want unknown or hidden antibodies to come back and cause problems the next time somebody receives blood. So these are the guidelines. And now I'm going to show you what parts of this is actually done at the blood operator level, either Héma-Québec in Quebec or Canadian Blood Services outside of Quebec in Canada. Again, this is a Canadian talk, and I know we have listeners from around the world. And I only know about how things are done in Canada, and that's what I'm speaking to today. Okay, so at Canadian Blood Services in particular, the blood operator, their job is to make sure there is blood available, and they should collect the blood and manufacture it into the safest product, the best quality product possible. So we have about 375,000 whole blood donors. And of these donors, about 60,000 of our donors have the type of blood antigens, the markers that are very important when matching it for patients with sickle cell disease, meaning they have big C, big E, and CAL negative typing, or so their genotype and phenotype has been tested for that. There's about 767,000 units collected per year, and then all of the donors are rigorously tested, including for the markers, but also for other things. Specifically, when people require exchange transfusion on an ongoing basis to support people living with sickle cell disease, about 15,500 units are used specifically for that. That doesn't include emergency transfusions that are required in scary situations when people have crises that only can be treated with a red cell exchange or have an upcoming surgery for which they need to be prepared and they don't get regular transfusions, for instance. There's also a rare blood program at Canadian Blood Services that includes additional testing of donors and a roster of donors who have the additional testing done, a regular contact to make sure that the donors are actually available to come in when they're needed, and a frozen inventory for extremely rare types of blood that can be sometimes required. On the patient side of things, so that's the blood operator manufacturing, building the inventory, providing the blood, and so forth. But the Canadian Blood Services and Héma-Québec as well, the blood operator is also responsible for doing specialized testing for the country. This includes antibodies that need to be detected, that cannot be detected at the hospital level. And that's more of a limitation because this type of expertise and the materials required to do that testing cannot be available everywhere. These are hard to source materials, and hence all of this happens at the National Immunohematology Reference Lab, which is situated in Brampton. The red cell genotyping as well for people living with sickle cell disease and for other purposes of people requiring transfusions is all done at our national reference lab as well. And then there's additional testing for during pregnancy, prenatal testing that may be required. If there are antibodies formed, we need to keep track of them and understand if they're going to be problematic for the growing baby. Other than all of this, there is HLA testing that is also done at Canadian Blood Services to support organs and tissues and transplant. Some hospitals, some transplant centers also do their own HLA testing. And there are other types of registries available. The stem cell registry at Canadian Blood Services is for unrelated donors. And in sickle cell disease, folks who are eligible for and happen to find a related donor for transplant, they're usually from a family member rather than a unrelated donor in the registry. But there is a stem cell registry as well. There's a paired kidney program for very hard to transplant kidneys as well. And some of these may come in to play for supporting our patients who are living with sickle cell disease, because just because somebody has sickle cell disease doesn't mean that they also don't have other things that they have to manage and deal with. And you can never predict other things that may happen in a lifetime. So these are sorts of things that happen at the blood operator level. So that's the blood operator. That's for Ontario, that would be Canadian Blood Services. This is where I want to give you a little bit of an overview of how this really complicated and bulky system actually is organized, and where are the opportunities for us to sort of think about, if we want to see improvement, where do we go? Who do we talk to? How do we make it happen? So the blood operator is a pharmaceutical, non-governmental, not-for-profit company. I'll repeat that again. It's a pharmaceutical company. It's a biologics manufacturer. It is an arm's length away from the government. The government, being Health Canada, is the regulator, meaning they give the permission and monitor everything that happens at the pharmaceutical company. The rules that are set by the regulator must be followed. And the purpose of these rules is to ensure there is the best quality product and a sustainable blood supply available at all times. Those are the sorts of things that Health Canada will have influence on and will give permission to Canadian Blood Services to operate in those parameters. The funding comes from territories and provinces, because healthcare in Canada is federalized, meaning every province is responsible for their own healthcare. Hence, the funding to support the products that is used in the province comes from the province itself. So the ministries of health are the ones funding the Canadian Blood Services as a blood operator. Okay. There are advisory committees that includes the National Advisory Committee that will set out the best practice as well as recommendations for how things should be managed in the world of transfusion, whether it be blood collection, blood transfusion, follow-up, or reactions and testing. There are provincial coordinating offices that manage the products. There are hospital blood banks that will then be the ones requesting the product on behalf of their patient, receiving the product, doing their own checks and ensuring the product is being used, the blood is being used in the way that it's supposed to be. Okay? And then on each end of this story, this vein-to-vein story, is a donor without whom there wouldn't be a blood system, and a recipient for whom this can be a life-saving therapy. Okay? So that's really the chain of how the blood system's organized. There is many ways of oversight and surveillance. This includes regulatory oversight, as I discussed with Health Canada, but a surveillance system with Public Health Agency of Canada as well. And very close monitoring of everything that happens at every step. So when we talk about these challenges, I think I've already alluded to some of these already, but we need to be very mindful of the fact that even today, there are gaps in what is happening to bring the best possible transfusion care to people living with sickle cell disease. And in the future, right now we have about 6,000 people in Canada with sickle cell disease, and we are clearly seeing increases in our need to be able to provide the best possible care for people. And there are various clinics that are still growing. We heard yesterday at the plenary from Dr. Ziad Sol as well, and the New Windsor program. There's clearly an increasing need for care for sickle cell disease warriors, right? And over time, there's only going to be a growth in the number of people who then need transfusion care as well. So how do we make sure we also prepare, not just for our today, but for our tomorrow? Right? So a big part of that also happens with understanding what needs to happen, how it needs to happen, and what can be done. And research and education is an important part of that. Research and education happens at the hospital level, at the very grassroots level with organizations like SCAGO. It also happens at Canadian Blood Services and HEMA Quebec as a blood operator, funding from provinces and territories to make those things happen. Here's some examples of some of the questions or some of the research that is happening right now that I am aware of at Canadian Blood Services, for instance, is we are working on a faster and more accurate type of genotyping to be able to do exactly the marker testing that we need. Because if the information that we're trying to use to match people isn't good, or the information we're using to test our donors isn't any good, how are we going to do the best possible matching that we can, right? We also need to understand, how do we make sure we keep having more and more donors? How do we bring people in? How do we make sure people participate? And there's social science research going on into understanding people's perceptions about being part of the blood system as well. On a very basic science need, there is also understanding, also research in the quality of the blood cells that have been frozen and how they can be thawed faster, how they can their safety and their quality can be maintained through the process, and how that process can be made to happen at the time that it's needed in the most timely manner possible. And then there are other ways of assessing donor eligibility that can potentially have a big impact on people with the same ethnicity and ancestry as people who are living with sickle cell disease, such as how the screening for malaria is done. So there's investigations into that. So those are some sorts of ways that things are being studied and the types of gaps that we need to think about. And here is Ulysses, who kindly shared a very important and beautiful message with donors as well. And I wanted to play that. Let me see if the volume comes through. Here we go.
Doesn't seem to be coming through there, Aditi.
You can't hear that?
Maybe if you undo your screen share, and then when you redo your screen share, I think there's a little button that says share audio.
Oh, I need, okay.
As a Black,
Can you hear that? Oh, yes.
Yes, we can.
Perfect. Thank you.
my name is Juliet Uchegbue. I was diagnosed with sickle cell S-beta thalassemia at the age of 2. I have received blood transfusion as a treatment every 4 weeks since I was 10. My genetic makeup as a Black person is different than people from other ethnicities. Without the support of blood donors like you, I would not be here today. Book your appointment today at blood.ca.
That's just a very brief message that Ulysses had recorded to urge people to come in and donate. So that's a bit of a bird's eye view of the blood system and what happens and the various ways potentially there's interaction between the blood system and helping how it may help support people living with sickle cell disease. But what's more important is, what does the sickle cell community want and need? What do people living with sickle cell disease who've been exposed to or maybe exposed to transfusion may need the blood system? What do they want to see happen? And how can we make that happen? So that's where I'll open up a discussion, and I'm happy to hear what other people have to say and questions they may have.
Fantastic, thank you. And if we were all in person instead of Zoom, there would be a large round of applause for both Juliet and Dr. Aditi Khandelwal for your presentations. So thank you both. And there are 2 questions in the Q&A, so we can take those first. And in the meantime, if others have additional questions, you have 3 options. You can enter them in the Q&A. You can enter them in the chat, or if you prefer to, for any reason, ask the question yourself, please raise your hand and we can allow you to unmute to be able to engage in some discussion. So we'll start first then with 2 questions from Karen Fleming. The first is there work being done to have a centralized system or even using Connecting Ontario to ensure all providers have access to the most up-to-date information about a patient they may see? And I imagine that question could be more broadly, but today I imagine Karen's asking that in the context of all of these unique transfusion needs and genotyping and antibody history that, as Juliet had really poignantly shared about her experience having the card. So that's one way to do that. But us being in 2023, what the plans are to take technology to the next level.
Yeah, I wish I knew the ins and outs of this topic. This has been brought up many, many times. We don't just need an Ontario-wide, but a national ability to be able to include this information and that be accessible to whoever is making that decision about transfusion. At the last update, I remember that a lot of folks in Ontario were appealing to the province for funding to make this happen. And from my last interaction on this topic, which was actually over a year ago, so I don't know if this is true today, but my understanding was that we're awaiting a response from the province about whether there will be funding. The proposals have been put in, and I know for a fact that CBS is in support of making this happen. So that's where we're at, Karen.
Okay, thank you very much. Well, that sounds promising. So yeah, and I like your thought there about making it national, right? And I think Canadian Blood Services is well positioned, but of course, resources would be a key aspect to trying to get something like that set up. So thank you. Next, the next question from Karen: can we do directed donations towards sickle cell patients at CBS blood donor clinics or drives?
Yeah, thank you for asking that, Karen. First of all, for people who may be interested in what directed donation is. So directed donation is a very specific kind of donation where people are asked to come in to donate for a very specific reason to support the need of one individual. Okay, so this is interesting because in the country, we do have the ability to make directed donations happen, but they're only required and recommended in very unique circumstances. Kind of what happened for Aaliyah, that was sort of a directed donation because we knew we were awaiting these donors coming in to support her need to be able to get the transfusions. However, the other National Advisory Committee on Blood and Blood Products, NAC, it's a mouthful, sorry, has recommendations of where directed donations are indicated. And there are two main reasons directed donations may be done. Directed donations are indicated for anybody for whom we cannot source blood at all, even through the channels of rare blood. So sometimes what we have to do is import. This has happened very rarely, but sometimes the blood is so unique that we have to import it. There are some challenges with directed donations. When a directed donation comes from somebody you know, sometimes there are challenges in being able to meet the screening criteria. Just relying on one individual to be able to complete the whole process may not be possible because there are many reasons why somebody may not be a suitable blood donor. They can range from reasons why the blood might not store well to it could be harmful to them, to there could be a possibility of harm to the recipient. So yes, directed donation is something that is currently possible, not just in the situation of overall in sickle cell disease, but very specific contexts. But we have to be very careful that it's used as it's intended and it doesn't happen. It happens with the right checks and balances in place.
Mm-hmm. Thank you so much for that. And Karen had entered in the chat some additional comments there that she wasn't familiar with that more formalized process of directed donation, and just reiterating kind of more generally whether when somebody is giving blood, if there's a way for them to tag it as saying, I want this to go to sickle cell patients. So whether that's ever been explored or what the pros and cons of contemplating something like that might look like.
I'll start with saying that I can tell you that so far, when blood has been needed for a person with sickle cell disease, even with rare blood group types, there actually has not been an instance where blood hasn't been found for them. Okay. I know I gave a sense, it's very true that blood transfusion in itself is very risky, and it's very true that we need a bigger donor base. There's no question about it. There are many challenges with labeling blood to where it's intended to go. We do that informally when we set aside, like we know we have certain number of chronic exchange recipients, and the blood is sort of reserved, set aside for them if it meets all of the antigen requirements, the matching requirements. So it's sort of tagged in a way to go to somebody living with sickle cell disease who is in need. At the same time, there are thousands of people in need. Every 3 seconds, there is a blood transfusion being performed in this country. There are reasons for people needing blood that cross many types of situations, and the antigen piece is very important in sickle cell, and it may not be when there is a lot of bleeding happening for somebody who's had an accident, for instance. So there's definitely a consideration for that, but whether you can guarantee who gets the blood from somebody who comes in with the idea of, I am here to help someone, and hopefully it'll help somebody who is in need. The idea of tagging that and saying, if somebody else needs it, you can't use it, that's worrisome. So we need to be sure that we meet everyone's need, and in a timely manner, and with the best possible product that is available. So I have mixed feelings about tagging somebody's donation and saying you can only use it for this purpose. Mm-hmm. Okay. I think it goes against the idea of a voluntary blood donation, a gift made with the hope that it will help someone, it'll help somebody, save somebody's life potentially. Yeah.
Very, very, very well put. And I see that Juliet's unmuted. Did you want to add, Juliet? Or, oh no, sorry, didn't mean to put you on the spot. Yeah, please.
No, I was just gonna, just add saying that it would be nice if we could have like a centralized donor for sickle cell patients. I know that's like a wishful thinking. Like today I was talking to my friend and she had to give some blood. So I wish like I get something like that, right? And she could go and say, I'm donating on behalf of sickle cell patients, right? For the cause, something like that would be really nice.
And there is
to have.
There definitely is. So there's something, the marketing people at CBS would know this better, because who run this program, but there's something called Partners for Life. And you can even create a blood donation event in the name of somebody you love and care for. Okay. So that everybody can go and donate in somebody's name. And what you can do is you can track everybody's progress. They don't even have to be in the same city at the same clinic. They can be anywhere in Canada, and they can go donate blood in someone's name or in an organization's name, or to commemorate something. And you can keep your progress in check. And that is totally possible today. You can you can create and share a QR code with your friends and donate together. So that is definitely possible, Juliet. Yeah, I know that for a fact.
That's fantastic. Thank you. And I think that starts to get at a bit of the spirit of that idea of directing it to sickle cell patients, and also allows that unit to be used wherever it needs to be used for the greater good. And that's really humbling that one transfusion of blood product every 3 seconds across Canada just gives us a very strong sense of what a complex system it is, what a complex web, and what a remarkable blood system we have in Canada. With just over 5 minutes left, I think the feedback survey is going to be popping up soon. With our last few minutes, so I'll encourage everyone to fill that in as it pops up. One other question I had, and I know we're not here to give medical advice or to really kind of go through medical, but I imagine that some people may have some questions about what Juliet described going through years ago, where she received the blood transfusion and then her level went down to 30. And I'm wondering if you can, I think we've got a good sense as hematologists of what likely happened there, which Juliet explained a bit. And maybe just for everybody's understanding, if you wanted to spend a minute explaining about hyperhemolysis. Yeah, thank you.
Absolutely. So Juliet described something that every hematologist who has ever been the one to write that order to help get that transfusion is always worried about, and that is called hyperhemolysis. Hyper meaning a lot of, hemolysis meaning cell breakdown. What happens, which is quite unique for sickle cell disease in itself, what happens is, despite matching for all of those markers that you know of that exist on the red cell surface that you've looked for, the ones that you're supposed to match for, right? Those ones. And despite matching for the antibodies that you've detected, there is a possibility, the hypothesis is, there's a possibility that you've missed an antibody. That happens because people, when they're exposed to somebody else's blood and they form an antibody, those antibodies, like I said, can hide. There is a time frame after transfusion when these antibodies can actually be detected reliably. It's about 3 to 4 weeks after. And that's why we recommend anybody who receives blood about 3 to 4 weeks after needs another blood test to look for these antibodies, because after a little while, they disappear. This disappearance of antibody, called evanescing antibodies, they cannot be tested for in the future if somebody is about to get blood. Like if I'm somebody who's had this hidden antibody, next time I go in, and it's beyond that 3 to 4 week period, I go in and I need a blood transfusion. If you look at my blood test and you try to look for that antibody, you can't find it, but it's there. And if I get exposed to that antigen, what's my body going to do? Going to destroy that blood. In hyperhemolysis, it goes one step further. For reasons we don't fully understand, it not only destroys the blood that has been transfused, meaning somebody else's red cell, the donor's red cells, the antibodies then start destroying the person's own blood. So it's ramping up, and it causes more blood breakdown than you would ever expect. And it's really scary. And in that situation, what has to happen very quickly is, one, recognize that this is happening, and two, stop it as soon as possible. Because it's an immune system problem, meaning the body's defensive system is ramped up, the treatment is immune suppression, calming down, suppressing the immune system. And some of the medications that are used for this, namely things like eculizumab, rituximab, a lot of these fancy names, expensive, hard to access medications, that can actually be a challenge. Other than steroids and so forth, and erythropoietin to start boosting up the body's ability to make blood, you need to calm down the immune system ASAP. Accessing these medications in a timely manner, and now there's also IL-6 inhibitor as well, tocilizumab, that can potentially be beneficial in this. But accessing those medications in a timely manner, getting them in as soon as possible, making sure not a touch of foreign donor blood enters and causes worsening problem, giving people immunoglobulin or erythropoietin. All of those steps need to happen very quickly and very carefully. And they cannot usually be done everywhere because, as you have probably realized, and you've experienced this, the understanding of how to care for complications in sickle cell related events, that knowledge and the resources are only available at few institutions in this province and in this country. So those are the sudden challenges that one has to encounter when we're dealing with hyperhemolysis. That's my long hyperhemolysis answer, sorry.
That was not long at all. And I was trying to look for a clap hands icon, but I don't have it on my screen. So thank you both so much. That brings us to the end of our time. There's never enough time to cover such a big topic. But Dr. Khandelwal, you've done a phenomenal job of bringing these things to a really bringing them forward in a very understandable way, and great Q&A. Juliet, thank you so much for joining us. for sharing your story, for really helping us to understand all that can happen when somebody's receiving a blood transfusion, and really the strength that you and other sickle cell warriors bring to every part of your lives. And thank you for contributing to this education. So we'll wrap up the session. And I think that brings us to close to the end of today. And you can join on to the other link for the session, the wrap up session. Take care, everyone.